Thank you, Your Honor. I'm Theo Allen. I don't have an affiliation to report, although I am aware of some links with participants. If you'd like me to go into that, and
I don't think that's necessary, sir, but can you speak a little more loudly? We're having difficulty hearing you, sir.
Your Honor, I'll try, but unfortunately, some things that happened over the weekend, i.e. COVID, may make that difficult.
I can hear you much better now, sir.
Thank you. And I believe I have two exhibits right now, Miss Tryon, and a third exhibit for questioning. I intend to submit shortly after we get all the questions done today. So if you want to admit that now, it would be a good time.
Thank you, Mr. Allen. Do you have any exhibits that you have not previously sent in by email to ets@dol.gov?
Only the only exhibit that has not yet been submitted is the list of questions that I haven't been able to ask because of the one question rule, which will be submitted shortly after we finish the hearing today, before 5 o'clock.
Thank you. All right. Well, since Mr. Allen brought it up, he had previously submitted a PowerPoint presentation, which I was planning to later ask, but we may as well ask now that his PowerPoint presentation be marked as, I think we're on Exhibit 9, and accepted into the record.
So accepted.
Thank you very much, Your Honor.
And Ms. Tryon, I believe I submitted as well written remarks that I won't be able to read because of what happened over the weekend. Can we get that in as Exhibit 10?
Let me confirm that we have received that. I need to confirm. It will be Exhibit 10. I need to confirm. I haven't seen it. I'm waiting for somebody to tell me whether we've gotten it or not. But I can check back in after you're done speaking, Mr. Allen. We won't forget about your exhibit.
Thank you.
You're welcome.
So the unfortunate part is over the weekend, I got a test. I took a COVID test, and this is a rapid test for the record. And unfortunately, it appeared that it was positive, but I will have to start with my objection to the scope of this hearing. Under Section 6B3 of the OSHA Act, OSHA was statutorily required to schedule by August 20th, 2021, a hearing on my objections to this rule, which were the denial that COVID is airborne and the fact that not all workers should have been protected, regardless of setting, healthcare, or otherwise. You have excluded from this hearing the other issue, and I can't waive it without sufficient assurances from OSHA. Next slide, please. I tested positive Saturday, but unlike 30% of low-income workers who had to actually go back to work for financial reasons, I can afford to isolate, and that's what I'm doing now. For example, Amazon recently eliminated paid sick leave for COVID, and we can expect healthcare employers as well as others to do the same. Dr. Julia Raifman's work shows that this is not in the ordinary course of daily living, and it has bigger implications. I'm on 3 million, which is a 2.5% drop in labor participation rate, who's not in the workforce because of COVID distancing, among other reasons, and because testing is not accessible very easily. I did not get tested earlier. If I did not get tested, I would have probably not exposed healthcare workers, although based on going to urgent care clinic Saturday, I saw tremendously pro infection control procedures that I would urge to be asked on. Those included violating the bloodborne pathogen rule, the ETS, hygiene theater, among other things. Next slide, please. So the previous slide showed that we had a lot of excess mortality, but healthcare, unfortunately, for this rulemaking was the lowest in California among all essential industries. But our public health response is the Great Barrington Declaration. Our economic analysis has been Dr. Emily Oster, a professor from Brown, who a Great Barrington Declaration co-author Jay Baccaria. And of course, the declaration was condemned by virtually everyone in public health in October of 2020, said that reviews are very valuable. Unfortunately, the precautionary principle no longer applies to COVID, and this applies to not only mandatory elastomerics and vaccine mandates, which is not unfortunately considering, but to mode of transmission. Next slide, please. Transmission-based guidelines didn't help me, and I don't believe it would have helped any workers, whether or not they're in healthcare, in getting infected. Had we followed them, there would have been a mask mandate. I would have worn this respirator mask. It's an N95. I probably would not have gotten, or I'm almost certain I would have not gotten infected despite not being fit tested or having a medical evaluation. We know that low community transmission and daily reporting on positivity is key, but the only way I could have gotten my tests recorded in my records was by getting a confirmation PCR test Saturday. I'd urge OSHA to make it easier by, for example, requiring all employers to record both long COVID and infection so that OSHA can actually find the data which the CDC is not tracking. And it costs over $200 for me to get a test to get confirmed. Most workers, especially your low-income workers in healthcare, can't afford that. Next slide, please. So, as you heard on Thursday from the American Public Health Association, and as I submitted from the WHO, occupational health is public health, and I'm urging the CDC, OSHA to reject the CDC guidance for those reasons. That includes, and I will say, because the slides are clear, that healthcare workers couldn't get PPE from Project Get Us PPE, designed to protect healthcare workers during the early stages of the pandemic, whose employers and otherwise could not get that. Project N95 now has done a lot, but it's not adequate. We don't have exposure notifications, and you have to rely on individual contact tracing, which not only, contact tracing is not only required by the OSHA Act, it's the standard public health measures. Its abandonment is implementing the Great Barrington Declaration. Using the CDC guidance for isolation, I would have only been exposing probably one person. Using COVID as airborne, I would have used 4 people. Next slide, please. So, as I said, on last Saturday at an urgent care clinic in Hartsdale, New York, I saw many of these useless precautions, although I did not see gowns being worn, which would have been required under the OSHA ETS. There was no medical evaluation. I had to wait a half hour before being screened, although the waiting room was empty, yet I saw healthcare workers not wearing any mask, just exposed to me had I not been wearing a respirator. And on hospital PCR testing or rapid testing, I don't understand how they're not doing both for both infection control and medical evaluation purposes. Next slide, please. If OSHA wants to protect healthcare workers, I recommend relying on the tuberculosis recommendations. It's technically not a standard, but it's been incorporated into 1930.134, which is mandatory respirators, negative pressure, early screening, and an adequate number of air changes. I was not offered early treatment, so I doubt how OSHA can think healthcare workers or others can get that. And incidentally, when I was speaking on Saturday, what I saw was clearly a lack of training, which I've been asking about Project First Line to multiple panelists and the links to it. The reason I did that was because the CDC's Project First Line is designed to protect healthcare workers from COVID. However, it contains hygiene theater, so I urge OSHA not to consider that. Vaccines, unfortunately, due to attacking the immune system, which one person says is similar to HIV, it's not a solution that we can rely on. Nor can we rely on burned out pharmacies doing this test to treat, which I can't see how it's only 30 seconds. Can we go to the final slide, please? Next slide. Because COVID's going to remain epidemic and not become endemic, the benefits to the hospitals, unfortunately, will be negligible. And that's if we limit the scope of this rule to only healthcare settings. I'm going to say that it's a cost-benefit analysis in some ways, but it's really more a patient demand, healthcare workers, staffing problem. With all the demand that's going to be pent up from a variety of reasons, including delayed care, even if we do this rule, it's not going to be enough to ensure safe staffing, which means relying on things such as travel nurses, which is prohibitively expensive for many, many hospitals who will be subject to this rule. I urge an urgency of equity to reduce transmission, not just in healthcare settings, but at a minimum in all essential settings, workplaces, preferably all workplaces and all indoor settings, such as a mask mandate, which we definitely don't have anywhere in the US even outside of individual workplaces, etc., which doesn't work. With that, I'll take everyone's questions. I need some water.
Thank you, Mr. Allen. Does OSHA have questions for Mr. Allen?
Good morning, Your Honor. This is Jessica Schifano from OSHA, and we do have a couple questions. Mr. Allen, we're very sorry to hear about your COVID infection over the weekend, and thank you for continuing on to participate today and sharing your information with us.
You're welcome.
I was wondering if you could give us a little more information about your concerns with the Project First Line training from CDC. You mentioned the inclusion of controls that were questionable for protecting workers against airborne hazards. Is that your primary concern with the training, or are there others?
Thank you for that question. I'll go into further depth now as to what I saw on Saturday, and it's actually a lot of concerns. But on Saturday, when I went in, let's start with the plexiglass. It was like 4 feet wide with 1 to 2 feet gaps in between, a big slit underneath. And when they wanted to come for my insurance, they just went all the way around the plexiglass and came to me, even though nobody else was in the waiting room. That's one thing. Two, over the course of the pandemic, I've asked, whenever I've been in healthcare settings, people to wash their hands. I haven't seen voluntary hand washing by anyone, even though, and last Saturday when I asked them to, they didn't even do it, even after removing gloves, which the bloodborne pathogen rule, as well as I believe the ETS would have required. Those are a couple of things. I also saw the use in new pens, and I saw a respirator not being worn correctly. But that all indicates a lack of training in that urgent care setting, and I believe it's consistent. The reason I'm concerned about Project First Line is because it's spreading inaccurate information, such as discussing respiratory droplets. And it recommends, for example, and this will be relevant to the OSHA rulemaking, contact precautions based on the bloodborne pathogens rule, which I'm not questioning, but we really need to separate the bloodborne pathogen rule from this rulemaking.
Thank you so much, Mr. Allen. That's a helpful clarification. You mentioned that in your experience this past weekend and in other experiences you've had over the course of the pandemic in healthcare settings, that you've noted a number of things that you were concerned about. So can you describe some of your other experiences and the sorts of protections that you identified as lacking in those settings?
Sure. First, in describing compliance with hand hygiene, I want to note that I've noticed 0% compliance in various healthcare settings I've been in among staff throughout the pandemic. And I've been to vaccination sites, I've been in a hospital, I've been I've actually been to a dermatologist. I've been to this urgent care setting. But that's some of the things I've seen. Others include, as I said, not wearing a mask when I went into the urgent care setting, not screening me quickly for COVID, and then just taking me to a room which endangered the frontline staff there, except that I was wearing a respirator. The old and new pens. And unfortunately, if we're going to try to protect healthcare workers, we can't give them a lot of things to do. We need to simplify it and focus on those controls that really help prevent the spread of airborne COVID. And while hand hygiene, for example, does not stop COVID, it's just deplorable that we're not seeing strong compliance with such an important measure against contact transmission.
Thank you, Mr. Allen. Just one clarification about your experience. When you mentioned that you were able to go in a waiting room with suspected COVID and sit there for over a half an hour before anyone came to address you and triage you, Were there other people in the waiting room at that point that you were exposing, as well as the other healthcare workers that were in that intake area?
There were one. It was about. I would not want to say it was over a half hour. It was about a half hour. There was nobody else in the waiting room, but there were two healthcare workers who, when I went in, they weren't wearing masks. I don't believe I exposed them because of my PPE. There weren't others in the room. Nevertheless, I would urge OSHA to make it clear that I'm not asking them to say we need to screen patients for COVID in a specific manner. In fact, the unfortunate part is, let's say you're going to the ER and you have a heart attack, you need CPR. You may not be able to screen for COVID. What I'm asking OSHA to say is, if it's a hospital, you need to do a test to screen. You need to screen as quickly as possible. And if somebody's suspected or confirmed to have COVID, put them someplace, preferably an isolation room, so that they're not exposing healthcare workers or others.
Thank you, Mr. Allen. So there were no screening procedures in place when you went this weekend to the urgent care facility?
There were no screening procedures other than that I told them that I was there for because I wanted a COVID test. And that should have been enough to just send me into a private room or to have me wait outside and go out and get me in from my car, but they did not do anything else.
Thank you for that clarification, Mr. Allen. We really appreciate your participation today and throughout the rulemaking process. We wish you a very speedy recovery, and I will turn it over to my colleague, Ms. Tryon, to clarify the entrance of the hearing exhibits that Mr. Allen provided him.
Yes. Oh, and thank you, Mr. Allen and Ms. Schifano. I just wanted to ask
Thank you, Ms. Tryon.
one more clarifying question about your visit this weekend to it was an urgent care clinic, right?
It was a City MD in Hartsdale, New York. I will say that I told a couple of the healthcare workers I would be testifying on that today. So I did not want to figure out their identities because I knew that then I could be forced to, unless the judge Henley made a ruling allowing me to submit it under seal, I would not want to expose their identity. So I tried to avoid getting that.
Understood. But the person who treated you at the clinic, was that person wearing a mask?
The person who was treating me at the clinic, I saw her. Well, there were two people, at least. In addition to some I could see in a behind waiting area who were at times not wearing a mask. There was the person who initially took my vitals, who I saw at one point wearing a duckbill respirator with one of the straps underneath her chin, like this, and the other behind the neck, none of it up on top. The doctor I did see was wearing a respirator. The time I did see her take it off in the waiting room briefly and then put it back on. In terms of other PPE, I did not see eye protection or a gown. I saw gloves. They definitely did not do hand hygiene at all.
How about the person there? Was there an intake person who's sort of the first person you encountered? Was that person wearing a mask?
There were two people at the intake. They were wearing a double mask. They were also not wearing a gown or eye protection, which I have no problems with. They were wearing gloves, but as I said, they were using plexiglass, which when I went there was like 4 feet with a 1 foot to 2 foot gap in between. And when they came for some other information twice, they came around the plexiglass and just came to me directly.
Thank you. And regarding your exhibits, as we discussed with Judge Henley earlier, your PowerPoint presentation is marked as Exhibit 9, and we did receive your written version of your testimony, and that will be added as will be appended to the
It
and go together with the PowerPoint. So
in
we're not going to
terms
ask to admit that as a separate exhibit, but we have received it. It will go into the record.
in terms of the questioning, though, I want to stress that on Thursday and Friday, we've had a very consistent practice, Judge Henley, of one question per panel, because I've read, just like OSHA has, the briefs of those who have filed a notice of intent to appeal. I've had several questions for a lot of the panelists, which I have not been able to ask. And that's the other exhibit that I intend to submit shortly after we close the hearing.
Yes, we are prepared to receive questions, ets@dol.gov by 5 p.m.
Yes,
Thank you very much.
Submitted multiple times to that for the record, and we've had no comments basically outside of email and maybe some chat beforehand. So thank you.
Thank you, and wish you well.
Thank you, Ms. Tryon. Are there questions from any other of the witnesses for Mr. Allen? Either through the chat or *3 for those on the phone. If so, please promote them to panelist.
I do not see any other hands raised at this time.
Mr. Allen, thank you very much for your testimony.